Hi. I'm actually more comfortable singing than speaking. And so if I suddenly launch into a little bit of Ella Fitzgerald, it's not Tourette's, I'm just having an attack of the nerves. So this is a talk, I will try to be relatively expedient with my time, but this is a talk that is largely based on something I gave in St. John's some time ago, and Aldo really liked it, asked if I would bring it to the national conference, so if you don't like it, he made me do it, and if you do like it, he made me do it, either way. So this is more just, I guess this is a sort of audiovisual representation of largely the kind of discussions that I have when I have a new patient with myeloma in my clinic. I have no financial disclosures that are relevant to this particular presentation. So I guess myeloma is one of those things that I have medical students and residents in training in medicine who come and sit before me all the time. They say, this is a black box, I don't understand it. So you can imagine that for patients and caregivers who are hearing this often for the first time, it is more so. So I'm going to just talk a little bit about myeloma. Some of you are very, very educated and experienced. This is going to be very, very familiar. For some of you who might be newer in your journey, some of this might be new information, but hopefully this is helpful. So we'll talk about what is myeloma, a little bit about what are normal plasma cells, because plasma cells are not all bad. So what are normal ones? What do they do? What goes wrong when you have multiple myeloma? How does it actually cause you to become ill? What are the elements of the disease that actually cause illness? And what can I expect if I or a loved one has multiple myeloma? Now, there are elements of this that are going to be discussed later in the meeting, so I'm going to try not to take too much time on things that you'll hear more about later. This will be largely just an overview. And we will talk a little bit about what we've continued to learn about myeloma, because there are some things that have changed about what we understand about the disease and its progression. I love this. I really wanted that shirt. It says, I have nice abs, like antibodies. Unfortunately, when I found the website, that one had been discontinued, so I was very sad, but I thought it was a perfect thing to put on my little plasma cell guy. So I think one of the biggest things about myeloma for people who are first hearing about it is they say the name can be confusing. What is myeloma? Okay, if I have lymphoma, I have something wrong with my lymph system. If I have breast cancer, I have breast cancer. What is myeloma? So what's the multiple all about? Like, some people have literally said, do I have several cancers or do I just have one? Well, the multiple, there's only one type of cancer cell, but there's multiple bony lesions, hence the reason they called it multiple. Well, what's about the myeloma? If you actually go back to Greek, and I'm a geek, so I studied it briefly once for fun. So myeloma basically means from the bone marrow. So why are not all bone marrow cancers called myeloma? Well, somebody decided it should be used to describe plasma cells in the bone marrow, and this goes back to the mid-1800s. And it's largely because inside the bone marrow, you develop tumors that would often grow from inside the bone marrow out, as you've seen lots of imaging discussion of. So they called it multiple myeloma because it had multiple bone sites, and these tumors would come out of the bone marrow. I like to call it plasma celloma because it is a tumor of plasma cells, and to me that makes sense. This is the white blood cell family. So if you have looked kind of at the blood system a little bit, you've noticed that on most pictures when they put up the blood cells, plasma cells aren't actually in there, even though they're part of the blood system. So those ones with all the speckly bits in them are called granulocytes, because those speckly bits are called granules. And there's monocytes, which are all over your body, in your blood, in your tissues, doing a good job of cleaning up nastiness. And then on the T cells and the B cells are what we call lymphocytes. So if those go a little nuts, you get lymphoma. So where does myeloma fit into this? Well, if B cells go as far as they possibly can in developing to the very end of their development, they become plasma cells. So that's where plasma cells fit into this white blood cell family. So they do belong. So what are they? They're part of your immune system. That's generally a good thing. So these B cells, how they develop into plasma cells, they get activated when they see intruders that are displaying these little bits on them that are called antigens. An antigen really being any substance that can stimulate the production of antibodies, trigger your immune system. And these B cells, once they get activated, they have a couple of options. They can become memory B cells that remember they saw this nasty little thing, whatever it is, around, or they can become plasma cells that make lots and lots of antibodies. So the B cell runs into this matching antigen. So all these B cells have they recognize different antigens. So one B cell will recognize one will recognize another, because obviously there's lots of things out there that can hurt us. So this particular B cell has recognized, oh, I have the matching spot for this antigen. And it engulfs it, it digests it, and then it sort of spits out these little fragments, and it waves them around in the air. And when it's waving them around in the air, then this T cell comes along and says, hey, I match that too. And then the T cell actually creates this nice little environment. It spits out these chemicals called cytokines, create this nice environment where the B cell can multiply, and you get all these antibody-producing plasma cells. So these B cells get really, really excited. They become plasma cells, and they make lots of antibodies. Making sense so far? Okay, excellent. So then when they're released into the blood, all these antibodies that have been created by this B cell, T cell partnership that are out there, they also recognize these nasty little intruders because they match, and then they can help the immune system to destroy the invader. And this is just another representation. So this is basically what they're doing. So here you go, red alert. You've been exposed to the antigen. You get lots of these plasma cells proliferating. They secrete lots and lots of antibodies. That little thing with the tail on is the bacteria. So the antibodies are sticking to that bacteria. They're binding to the evil invader, and they call in the army. So we've got the heat-seeking missiles, which is called complement, and that basically comes in and punches a bunch of holes in that bacteria, so it dies. And then the foot soldiers are the macrophages. Remember those big kind of wiggly ones? Well, those macrophages come in, basically eat up the bacteria, digest it, get rid of it. So plasma cells, the thing about a normal, healthy, happy plasma cell, they are like the hero in a Western movie. They sort of ride in, save the day, and then they ride off into the sunset. So they don't hang around. They don't clog up the town. So I'm a geek, and I'm from Western Canada. This is all going to come out during my talk. I apologize. So what are antibodies? These are the antibodies that these plasma cells are producing. And they are proteins. That's what their definition is. They are proteins that help to target these invaders. So when people hear about the protein, they're like, so if you heard I have a certain type of myeloma, I have IgG kappa myeloma, I have IgA lambda myeloma, I have light chain kappa myeloma. Well, that's referring to these parts of this protein. So I always do this when I'm describing to my patients what the antibody is. So this is the Y, this is the heavy chain. Okay, so this is the part that is IgG or IgA. And then there's extra little niggly bits at the end, which are those lighter colored bits, and those are your kappa chains. And those kind of give your specificity to your cell, that kind of make it more targeted. So if it's IgG kappa, that means you have the IgG chunky part and the kappa niggly bits. So, going to talk a little bit about clones, because that term has probably come up as well, and that can also cause some confusion. So multiple myeloma is a clonal disorder. Technically, virtually every cancer is a clonal disorder. It's good cells gone bad. So, are all clones bad? My husband is a huge Star Wars fan, and so my kids are all going around humming the Star Wars theme, so it's stuck in my head. Clonal proliferation, though, is not all bad. So why does it even exist in the first place? Why are we capable of something that can give us cancer and hurt us? Well, in this case, in the immune system, it actually makes sense, because if you have one particular kind of invader in your body, then you have to have one particular kind of response to attack it. It has to match that invader. So a clonal response is actually normal. So if you get a bad viral infection, you're going to have one cell type that responds to that that's going to be very active at that time. But then once that infection is gone and you're safe, you should be able to get rid of it. So multiple myeloma is clonal proliferation. You guys remember the Gremlin movie? You can't get it wet. I don't remember all the stuff anyway. My parents wouldn't let me watch movies, and this was one of the first movies I ever saw at a friend's house, and I didn't sleep for about 3 months. So basically, if you have a clone that goes bad, you get the gremlins. But if the cells are good, they're more like cute little mogwai. So just to put a little bit of human face, what does myeloma look like in our population? So men more than women, but only by a little bit, so definitely a good scattering of both. Most common age of onset is usually somewhere between 60 and 70, but we've had patients as young as their 20s. Very, very, very rare in childhood, though. It's exceptionally rare. So it's almost all adults, and most commonly over 40. It's only about 1% of all cancers, so if you go to, say, an average family doctor's office, they might have a limited knowledge of myeloma, because realistically, they probably don't have a huge population in their practice. But for us as hematologists, it's 10% of all blood cancers that are out there, and so for us, it's actually quite a large part of our practice. And because patients are doing so well now, yay, we have a lot of patients who are in our practices for a long time doing well with their treatments. More prevalent as well in some ethnic groups, so it does change a little bit in different populations. And you're gonna love me again, Aldo. So what about some of the people famous people who've had myeloma? Well, Tom Brokaw was an NBC anchorman, arguably one of the more famous journalists in the US, who was very active for many years. And he remained actually very active in his community after his diagnosis of myeloma. He had an auto transplant, remained quite active and was involved with research, and as were many of his friends then by association. Ann Landers was an advice columnist. She was diagnosed at a more advanced age, but she also had myeloma. Roy Scheider, again, very active in the celebrity population. There were many of his celebrity friends who probably learned about myeloma for the first time, I'm guessing, and they actually became quite active in fundraising and advocacy in the US. And he did, again, quite well with his disease for many years, remained quite active. And Geraldine Ferrero she's a very inspiring woman who was the first female vice presidential candidate, a very active advocate. And she, again, with her myeloma, she didn't let it slow her down much for a long time. Lisa Ray, many of you might be familiar with. I would say that Water might be her most famous movie, but she became a very active sort of Canadian advocate for myeloma, very, very open and honest about many of her experiences with the disease. And this is one of my personal heroes. And I know he hates it when I do it, but honestly, I have days when, I've got 3 kids, I have a lot on the plate, and sometimes I get tired and I get grumpy. And I think, I think about just Aldo and the incredible inspiration that he is, and I could not have been more excited when he got the Exceptional Service Award at CCTG this year. But it was just, I felt so glad everybody agreed with me that this is one of the most remarkable individuals with myeloma that I think we've ever met. So talking to you a little bit about what happens when the plasma cells actually start to malfunction. So we talked about what good ones do, so what happens when they go bad. So normal plasma cells, they come when you need them, they go when you don't. They're only producing antibodies to stuff that's bad for you, and they produce as much as you need, and then it disappears. So they're not destroying good, healthy tissue, they're just destroying the bad things that might hurt us. Abnormal plasma cells, we're plotting. Abnormal plasma cells are the opposite. They fail to die. They fail to die when they should. So these are bad cells. They ought not to live. Our body, believe it or not, our cells are actually programmed to die when they malfunction, which is one of the reasons why more of us don't have cancer. In this case, that programming doesn't work, and they also divide when they shouldn't, so they just keep growing and growing and growing. And these can produce harmful antibodies, and not only do they produce antibodies that hurt us, but they suppress the production of the good antibodies that help to keep us safe. And they can produce these huge, huge quantities of antibodies and actually destroy good tissue. So these plasma cells, obviously way too many, and they're behaving very badly. So what does multiple myeloma look like? The classic features, which have already been referred to, the CRAB features, hypercalcemia, kidney disease, anemia, and bony lytic lesions. And I'm not going to go into that because that's already been gone to in a lot of detail. But we now have these new slim CRAB criteria, which were also referred to because they now involve this MRI. There's also this issue with the serum-free light chain ratio, so we sort of felt like there were patients that we all knew, looking at their numbers, were probably going to progress. A lot of them get picked up by the fact that if those light chains are really out of whack, it shows these cells are probably a bit more active. And so that is now one of the criteria we use to treat, not just to monitor. And if you have a lot of plasma cells in the bone marrow, over 60%, even if you've got no symptoms, it's almost inevitable that you will. So these are a new part of the criteria for treatment. And again, MRI lesions, and you've seen a whole lot nicer imaging than that already. So other things that people may or may not have experienced here, spinal cord damage and spinal cord compression can be quite a concern. As you've seen, there is a lot of this damage that involves the spinal, or involves the vertebrae, the spine. If that damage in the spine starts to, either because the bones are breaking and squishing into the spine, or the tumor is actually growing towards the spine, can cause compression. Infections are very, very common, particularly lung infections. So often patients start getting pneumonias that don't seem to make sense, and that can be part of how they present. The blood can get very, very thick, because you can imagine if you've got a lot of that extra protein in your blood, way more protein than you need, it's going to make your body blood quite thick and sludgy. And these proteins can actually get into your nerves, cause some nerve damage, and the calcium levels can also cause symptoms in your nervous system. So there's a lot that can go on, and some people can have only one feature that shows up, and some people can have many, many. It's quite variable. And this is another illustration that just shows how this all happens. So the myeloma, you have the marrow infiltration. You basically have cancer cells that start to fill up the bone. There's no room for the good cells to grow, so you get low blood counts, particularly anemia is very common. And then as part of this, as these plasma cells fill up your bone marrow, they also cause a lot of these cytokines, these chemicals to get kicked out that kick up the bad parts of your immune system as opposed to the good parts. And this can cause destruction of your bone, which, again, bone pain, high calcium levels. So that's sort of where that comes in. Because the good proteins are getting suppressed, you get the low levels of good immune globulins, get immunodeficiency and infection. And then the protein itself can cause all sorts of damage. The thickness in the blood is the hyperviscosity and kidney failure. So it's like there's multiple things that these cells are causing. So your upfront testing that you'll generally see in most individuals, you're going to see blood counts to see what the blood levels are doing. The serum protein electrophoresis picks up that heavy chain of the protein, and the light chain assay will pick up the light chain. You can either pick that up through the serum-free light chain or a 24-hour urine. I don't have time in the scope of this talk to talk about one versus the other or both, but that's a really interesting debate going on right now. Kidney function, particularly the creatinine, is the test that we use to very closely follow the kidney function. Calcium levels are really important, and the skeletal survey and other imaging, and then as we've heard previously, and the bone marrow biopsy is really where we go in to make the diagnosis as a rule. Now, some people only have tumors. The bone marrow actually doesn't fill up the same way, and then we need a biopsy of a tumor, but in most cases, the bone marrow gives us the really useful information we need. I would imagine. How many people have had to have more than one bone marrow? Yeah. So fortunately, we are doing less of those now than we used to. We used to do a lot more of them during the course of the disease on average, but unfortunately still a necessary part of our testing. So again, just to sort of recap, how is it causing problems? So the overproduction of the myeloma cells, again, dropping the blood counts, destroying the bones, sometimes causing these big solid tumors that can squish onto things, and you can generally just feel unwell. These are taking up a lot of the energy that your body needs to function, so you'll often feel just kind of generally tired and unwell. The bad antibodies that can make your blood thick, they can cause this thing called amyloid, where they basically stick together and become kind of gluey, and they can cause damage to different parts of the body. And these light chains are very toxic to the kidney, hence the reason that kidney damage is such a big issue with myeloma. And the infections, of course, because of the low antibodies. I'm just about done with this part of the talk, but just wanted to talk a little bit about prognostic features with the first part of diagnosis. So the degree of anemia is important as one of the prognostic features. If high calcium levels are involved, your age, so when you're older, you tend to have a rougher time, partly because your body has just been around longer and doesn't have quite the plasticity, we call it, the ability to bounce back, and sometimes it affects your ability to receive certain treatments, and also your general performance status. That refers to just how much you can get up and around, how much get up and go you have. If you don't need much, that's generally a sign that things are a little worse, as opposed to if you're functioning at 100%, that's a good sign. The number of lytic lesions, the number of spots on your x-rays or other imaging. Your genetic abnormalities, talk a little bit more about that in a second. The amount of protein, obviously a lot higher levels give a higher disease burden usually than if you have a lot lower levels. The amount of albumin, that's a good protein that helps to make your blood the right thickness and helps to carry proteins around and generally works in the function of your body. If that is low, again, it's a sign that your body is more unwell. If it's normal, that's a sign that your body's probably coping quite well. And there's something called beta-2 microglobulin, which is, that actually goes up in many different kinds of cancer, lymphomas and myeloma particularly, but many cancers. And is, again, if it's very high, it's associated with things being more active and not as good. Genetics, we are kind of learning almost trumps everything, though, because there are certain, and these are not, one thing that I really am very careful to clarify for people is because they say, well, is this something I'm going to pass on to my kids as soon as they hear the word genetics? No, this is not something that you're born with, and it's not something that you pass on. These are genetics in these cells that have gone bad. It's their genes. It's these cancer cell genes. And there are some that do well with treatment and some that do not quite as well with treatment. And we have really learned that we can put together all the other prognostic scores we want, but they're incomplete if we don't include the genetics. So that it gives us really useful information about how well we expect our treatments to work. Just a couple things we've learned as well, which has really come up even since I started my training, which of course, because I'm very, very young, was not that long ago. Myeloma, in a sense, is not just one disease. As I've mentioned, you can have one person might just have low blood counts, and that's it. One person might just have bone pain and high calcium, but their blood counts are fine. So myeloma really behaves differently in different people, and some of that has to do with genetics, but there's probably some other factors we don't understand well. So it's almost like you're treating multiple diseases under one title. It likes to surround itself with bad company. That's actually been very useful information. I call it the myeloma mafia, and it's like all these cells that are part of the system in the bone marrow that are part of the milieu, they call it, or the environment that the myeloma cell has. It's like it recruits these cells to kind of help it to thrive and survive and keep anybody away who might keep it from growing, so including some of the cancer drugs. By understanding that, if we can actually treat patients with things that change the way the bone marrow is, then our treatments work better. And that's some of the idea behind the auto stem cell transplant, is it actually probably changes the structure of a bone marrow, but makes it less hospitable to the plasma cells. It can do different things at different times. So even in the same patient, we can see that one presentation of their disease might be very, very different than another. And we have learned that we should be treating some people early in diagnosis, and that's where things like the MRI and the serum-free light chains have helped us. So we're treating some people earlier, not waiting until they get really sick, and also early in relapse. So when I was very early in my training, it was more standard to just wait until people had symptoms again. But if you have someone who has had symptoms with their myeloma, unfortunately, it's pretty much inevitable that someday they will have symptoms again. So now we treat when the protein levels go off, as a rule, as opposed to waiting until people are sick again to treat them. And that's actually surprisingly a change in the past 15, 20 years, really. And we talked about the genetics. It's probably one of the most important indicators, and maybe will someday drive our treatments if we are able to learn which ones work better with different treatments. We're starting to move in that direction. So the way I kind of describe myeloma being almost more than one disease is, it's a different monster. So Godzilla versus the Hydra. If you have certain things, I would say, again, something that might be more common that people know about, like lung cancer or breast cancer, if you have it, it tends to be one disease that tends to largely behave the same way over time, just become more aggressive. So it's kind of like Godzilla destroying the city. Myeloma is more like the Hydra. So when we give you chemotherapy, if you think about a Hydra having lots of heads, if we give you chemotherapy, maybe we're cutting off a bunch of heads of the Hydra, but then these ones are going to start to grow. And then we might give you a different treatment and cut off those heads, but then these ones might start to grow again. So that has affected our understanding and our treatment by saying maybe we can revisit some treatments. When those Hydra heads start to regrow, maybe we can revisit those treatments and cut off those heads again. Maybe we need to combine more treatments, so we're cutting off all the heads of the Hydra and not letting one or two escape. To introduce you to the myeloma mafia, these are kind of the cells that are normally present in the bone marrow that, again, if they're doing their job, they're helpful, but when they become henchmen to the myeloma, they're not so helpful. So the orange ones are the osteoclasts. Those are the ones that cause the bony breakdown. The blue ones are the macrophages. Again, when they're behaving, that's fine, but they can actually kind of help to protect the myeloma cells to some extent when they're in the bone marrow. And those are bone marrow stroma cells, or the pink ones. The green ones are dendritic cells. Again, they can kind of perform, some of the chemicals they secrete and some of the ways that they grow can actually kind of protect the myeloma and shield it from the normal responses of the body to cancer and to some of our drugs. And then the T cells can sometimes get in on the action as well. So there's whole parts of the body that actually get sort of dysregulated by the myeloma when it makes this little mafia. And just to sort of put it out there in case any of you have heard this term over the past few years, there's something called clonal tiding. And so this is our old understanding of myeloma. It was basically you have a smoldering myeloma, and then you get symptoms eventually. You treat with drug X. What's left must be resistant to drug X. Okay, it grows, you treat with drug Y. What grows after that, you would assume is resistant to X and Y. Second relapse must be something, again, that it's kind of different. One disease basically just becoming increasingly resistant. That's probably not entirely true. And so this is a really neat little chart, I love the fact that it's so colorful because I think it really highlights what's going on. So this is one person's myeloma. This is just one person. All of that came from one. But if you can see there's multiple colors present, that's different myeloma clones present in this person. And as you can see, they're getting different treatments over time. And as they're getting different treatments, different colors come out. That means that a different clone has kind of become dominant at one point. Then there's another treatment. That one kind of goes down and another one comes up. And then at the end, what they actually had was something called plasma cell leukemia, when these plasma cells actually escape the bone marrow and start swimming around in the blood. And it was a totally different one again that had kind of popped out to do that. So this is the idea that different clones, different parts of the cancer, different subgroups probably come up and down at different times. And so maybe by adjusting our treatments, if we knew how to do it really well, we might be able to keep all of them under better control. We're still learning how to do that. You probably also heard more about serum-free light chains. How many people get their monitoring done with urine as opposed to, so does anybody still doing 24-hour urines for monitoring, having to collect their pee? And how many are getting the serum-free light chains done instead? Okay, so that's not unexpected. So the serum-free light chains do pick up things more sensitively than the urine, and it's sort of much more easy on the patient. So I think that has been the general shift across the country. I know access has been somewhat variable. This was initially used more to assess for what we call non-secretory light chain myeloma, because some people don't make the heavy chain, so you can't follow it. There's nothing there to follow. All you had were those little niggly bits in the blood, which weren't really picked up with that part of the test. So initially, that was really more what this was used for. But now we use it for diagnosis, because remember, it's actually one of the criteria for treatment, so we kind of have to know in patients we may be treating. And also, if people are starting to progress early, it is part of the criteria to change treatment or restart treatment in patients when their disease starts to progress. So sometimes the heavy chain progresses, but again, sometimes this is actually our first and best clue. This just gives you an idea of some of the common cytogenetic abnormalities that we look for and why they matter. So the big bad wolf, as I would call it, is probably the 17p that's at the bottom. That's still kind of the bane of our existence, and that none of our treatments really seem to work very well. So we've certainly got better at treating everybody. Everyone's doing better with better treatment, but these people with these high-risk cytogenetic abnormalities, such as 17p, are still doing more poorly. So the genes still give us a lot of information. So the poor ones basically are ones that don't do as well with treatment. The ones that are neutral, it doesn't seem to make a lot of difference whether or not you have those versus not. So what does it really mean? Well, it is non-curable, and that is one of the hardest things you have to tell somebody who comes in, because, you know, when they find out they have a cancer, telling somebody, I don't have anything that can completely fix this. I'm a doctor. I like to fix things, and I can't completely fix it. I can never make it go away for good. And so that's something that needs to be understood. But the really important thing to remember is that it is treatable, and the better we get with our treatments, the better we're doing for longer periods of time. So that is the really important take-home, I think, from this entire weekend. This is a treatable condition, and we're doing better all the time. So that is the end of my first presentation.